Hi, I'm Dr. Terrence Manning. I'm a physician here at Restore PDX in Portland, Oregon. I just wanted to provide some feedback and comments about a recent article that was published in the Journal of the American Medical Association, or JAMA. Now, JAMA is a highly reputable and well-respected journal. I usually get updates on their publications through my email, and today I was excited because one of their highlighted titles pertains to what I am very passionate about and use daily on a clinical basis, and that being platelet-rich plasma. Usually, their articles don't have too much impact on what I do on a daily basis, but today was different. I opened this article with high hopes and was really excited to see what their study had shown. The title of the article was Platelet-Rich Plasma, or PRP, injections versus sham injections for chronic mid-substance Achilles tendinopathy. I had expected to see, because I have seen lately over the years, mounting evidence and a lot of good studies showing more and more support about the effectiveness of PRP for things like Achilles tendinosis, rotator cuff tendinosis of the shoulder, hip trochanteric bursitis, knee osteoarthritis. So I had expected that this study was going to be favorable like the other recent ones have been. Unfortunately, this study, where they compared the injection of what they call PRP into the Achilles tendon versus just putting a needle without injecting any therapeutic substance into an Achilles tendon, showed that the sham group, the one that just had the needle placed without any therapeutic substance injection, did just as good as the PRP group. Now, when I saw this, it contradicted kind of the trends that I've been seeing in the publication and published literature. So I wanted to look into it a little bit more detail to try to figure out what the heck was going on here, because it just didn't follow what I've been seeing in the literature, nor what I've been seeing clinically. Clinically, I see PRP to be very effective for things like chronic Achilles tendinopathy, rotator cuff tendinopathy, lateral epicondylitis or common extensor tendinopathy, bursitis and tendinopathies all over the body. PRP tends to do really good. So as I looked into this study, one first immediate red flag was the fact that their PRP processing was done in a method that used a very, very small starting volume of blood. The original blood draw started with 9 mLs of whole blood. So they, as with all PRP, it starts with a blood draw, and we draw a certain amount of volume of blood in order to make sure that we get enough platelets, raw product of platelets, so that when we get rid of the red blood cells, we can concentrate the substance and get rid of the platelet poor plasma. But the amount of platelets that we have at the start, that we have to work with, that we can then inject into the target tissue, depends on the starting volume that we draw. 9 mLs is a very low starting volume, and I don't know of anybody in the United States who practices regenerative medicine in a reputable fashion who only starts with a blood draw of 9 mLs. Anyway, so that was a red flag. And then the other thing that I noticed is they were using a platelet processing method using a kit that I was unfamiliar with. Now, there may be new kits out there and kits across the world that I'm not familiar with. I don't know everything about PRP and the direction that the field is going, but I try to stay on top of it, and I have stayed on top of all the different kits, and ones that are in favor and falling out of favor, and those that are showing promise, and because I want to provide the best product for my patients. Well, the kits that they were using, nobody that I know of who is doing regenerative medicine at a high level is using them. Nobody that I know of is starting with an initial volume of whole blood 9 milliliters. Most people are using at the very minimum 60 milliliters of whole blood as a starting product, and then making their PRP from there. Here at Restore PDX, we're commonly using upwards or about 240 milliliters of starting product. So what that means, if you think about it, if you start with 9 mLs of blood, you only have a certain amount of platelets. Now those amount of platelets, you can concentrate that several times, but probably only about 2 to 4 times given the such small starting volume. Depending on how much you dehydrate it and get rid of fluid volume, you can make the concentration look very high. But with that initial small volume to start, you start with a small total number of platelets. Whereas if you start with a larger blood draw, something like 60 cc's, over 6 times the amount in this study, or even 240 cc's like what we're commonly using here, you're starting with a very, very high number of total platelets to begin with that we can then concentrate and use therapeutically into these tissues. One of the things that we tend to see is that the more potent the PRP, the better the efficacy, especially after a single injection. So the PRP product that they use in this study was far inferior, and ultimately it's misleading. The results of this study are disingenuous and misleading. In fact, I question the peer review process that JAMA used for this paper, because anybody that is familiar with PRP or uses it clinically on any regular basis would know that what they were studying in this study is not PRP. What this also brings into question is another interesting point for the academics to discuss, is that we need to have a better standard within internationally and nationally about what is PRP, what constitutes PRP. Historically, it's been quantified or characterized based on 2 main factors. One of them, the concentration compared to baseline, and the second being whether or not the product has leukocytes or white blood cells, whether it has concentration of those or not. So usually it's been reported as this PRP is blank times the concentration, the baseline concentration with or without leukocytes. The issue is you can adjust the concentration and inflate the concentration just by making the volume smaller and smaller and smaller and dehydrating the sample and sample and sample. But you still may have a very small number of platelets that you started with and still have a very small number of platelets despite having a high concentration that you're injecting into the final tissue. So what we should be moving towards, and what those of us who are taking this seriously in this field are moving towards, is to quantify our platelet products based on a total platelet number. And that can easily be analyzed, and we can use a hemocytometer to get that number, where after we get our PRP product, we put a little sample of that into the blood counter, and it'll give us a count of how many platelets per mLs are in there, and we can multiply that by how many mLs we have of the final product to get a total platelet number. What we see clinically and what the reputable studies are showing is that in general, the higher total platelet count tends towards a better efficacy, whether it be for arthritis or tendinosis or partial tendon tears and such. So with this study, obviously the peer review group wasn't expert in using this type of product, and probably overlooked the fact that despite this study having a great study design, it is the gold standard study design, where it was a randomized controlled trial and it had a high number of patients in each control group, and the sham intervention was a good comparison. Yet the product of the peer, so just because they had a great study design doesn't mean that the results of this study are trustworthy or valid or make any impact clinically. So unfortunately, JAMA really missed the mark on this one. One other thing specifically about this study that I think bears mentioning, and that is in this intervention, they did a good job of diagnosing and screening their patients for chronic mid-substance Achilles tendinopathy. They used either MRI or confirmed it with ultrasound, and the patients had tried conservative care, but they weren't getting any better after 3 months. So those are all good markers and a good selection of the patients that should be included in the study. But the issue is the PRP was not what we would consider PRP. And secondly, the way that the PRP was delivered is not how anybody that's serious in this field delivers the therapy. People who take this field seriously and who do this on a daily basis basically have a standard of care of using some sort of image guidance to deliver PRP or whatever regenerative medicine product that they're delivering. What that means is that we can use an ultrasound machine or a live x-ray to see the needle go into the tissue and administer the PRP directly into the tissue where it needs the medicine. What we find is that this precision delivery helps get a better outcome. If we don't put that needle directly where the diseased part of the tendon is, and we miss that spot, we don't get nearly as good outcomes. In this study, they went against the image guidance standard of care, and what they did is use palpation, so they didn't have any image guidance and they didn't know where that needle tip was as their injection technique. So 2 big red flags that really call into question this study, and I would hope that those in the medical field who are looking at evidence for the regenerative medicine injections can really take this study with a grain of salt. It's a good learning experience about what it looks like to be doing these regenerative medicine and interventional orthopedic procedures at a high and skilled level versus at a level that isn't quite the industry standard. But also, we have a lot of patients who do their own research and they advocate for themselves, and they come to us because they've been told, hey, you just got to do more PT, you got to do more exercises, it'll get better, give it more time, it'll get better, it'll go away on its own, there's nothing wrong, just keep doing your exercises and it'll get better. And they're suffering through and it's not getting better. In fact, it might even be getting worse. And so they find studies on PRP or regenerative medicines and come to us and ask whether or not it might help. Well, if they find this study, they may be dissuaded and not know the expertise that it takes to do these procedures and get good outcomes. So this study is a disservice not only to clinicians who are considering using PRP or orthobiologic therapies for musculoskeletal conditions, but also to the patients out there who are trying to get help for chronic tendon ligament issues that aren't healing and aren't getting better with conservative care. So just a cautionary tale of what it looks like to be doing these practices legitimately, to find a clinician that can administer these therapies legitimately, and also beware of those studies out there, because this is a reputable journal, a very sound study designed, but it falls short in 2 key areas. Therefore, it should be taken with a grain of salt. Well, sorry to make that so long-winded, but I hope that those of us who are serious about regenerative medicine will come out with some studies that refute these findings, and strongly so, and show what a good study with a potent, clinically relevant PRP, what that can do for Achilles tendinopathy. Anyway, thank you, and hope you have a good rest of the day.